Hi,
All right.
this is Leanne Eagle from Maryland, and I'll be the only one on the call.
Okay. Hi, Leanne. Great. We're just about to get started here. So this is Anna Barnes at the Illinois Public Health Institute, and I'm here with Antonia and Lori. We are going to kick it off with a few icebreakers here. So let's see. I know we have Lutheran on, so if someone from the Lutheran team can share one interesting conversation you had recently that relates to your work for the Learning Collaborative, or one new thing that you learned.
Are you starting off with in Maryland, or are you just waiting for all of us to join?
I was starting with Lutheran because since you had just jumped on, Leanne, I didn't want to put you on the spot.
So you want to know one interesting thing we've learned from the Learning Collaborative is that what you're...
No, one interesting conversation you had recently related to the work that you're doing as a part of the Learning Collaborative. So related to your work plan.
Okay, sure. I would say the one interesting thing that we have learned is we really need to be able to network on the clinical side with an with an EMR, and we have been able to do that. And we actually have 2 potential billing sites to date that we hope to launch in the next 30 days.
Can you say that again, Leanne? You have 2 potential what sites?
Billing sites to run billable services through the community-based programs to be able to bill for what we're doing.
Great. Wonderful. From Oregon, I believe we have Lavinia and Kate and Jennifer on the line. If someone from the team can report on one interesting conversation you had recently that relates to your project or one new thing you learned.
Oh, we're always having conversations about the topic. I don't know if I can think of one particular thing. I think we're constantly listening for what other agencies are having success with. So I know we did pursue the one that was mentioned last month, and are still trying to pursue that one. So I think that was beneficial. We're always, in fact, if you have any other ones, that's what we'd like to hear about, so that we can see if it will work for us as well. But I don't know, Jennifer or Kate, do you have anything to add?
That's okay. We can just move on to the next site. Thanks, Lavinia. And we have Nikki from Western New York.
Hello. An interesting conversation. Well, we went back to a previous IT portal that we vetted previously, and we're also speaking with physician group that we might be able to actually use the portal under them. So that I just had a conversation with them today. So that was pretty interesting.
Oh, is it one that is it a national one?
Yeah. So which one, the portal or the physician group?
The portal that you're looking at.
Yeah, it was the one we vetted over the summer, the EHI.
Oh, really?
Yeah.
Oh, Nikki, you and I have to have a conversation.
Yeah.
Great. Well, it'd be helpful maybe when we circle back at the end on further updates, Nikki, for you to share a bit more about that with everybody. Okay, great. Do we have Rob on the line from Age Option? Okay, I don't see him on the list yet, so we'll just go ahead.
Hi, this is Joan.
Oh, hi, Joan.
Joan and Peggy are here today. Rob is out at a meeting.
Perfect.
So what activities we've completed or achieved in the past 1 to 3 months. We worked to update our data management system, so it allows us to create more related reports. And as far as one of our hurdles, we need to overcome in the next 1 to 3 months. In order to upload systems even in the future, we need to check and see if our budget will allow it. And as far as the third one, is there any questions or challenges? Not at this time.
Okay. And Joan, have you had an interesting conversation about the project specifically? Have you spoken with any partners or vendors?
Well, we've been working with the gentleman that owns our Wizard site and working with him with different functions that we need to, complete our jobs in a timely manner.
Okay, thank you. And can we circle back to Lutheran Services of America? We have a full team on today. Swati or Alicia, will you be speaking?
This is Swati. So I can briefly discuss that we had a great conversation with Drew Chrysler. I mispronounced her last name. I apologize. And I don't know that much about the technical backgrounds, but it was a great discussion in that we were happy to kind of just have a conversation that this issue of data sharing is an overall issue. And it was great to hear another organization, another person going through kind of the same struggles. So I guess it was great to are validating the idea that this is an existing problem with data sharing and getting consent. So we were glad to have that discussion overall. I don't know if my team wants to go into more in depth of specifics on the technical side, but that was the big that I had.
That's perfect for the introduction, and your colleagues will actually be sharing more about that conversation later today. So we'll get to that. Thank you. So I think I'm going to pass it now to Lavinia. We have one more community presentation. We've been doing these on each of the work group calls. So today, Lavinia will be presenting from Oregon Wellness Network. And we will pass the slides to you.
Oh, okay. How does that work?
If you hover your mouse in the bottom left-hand corner of the screen, you'll see a little arrow left and right appear that'll let you advance.
Okay, so I see the screen. I'm hovering.
There we go.
Okay, all right.
Great, thank you. Take it away.
So actually, there's going to be 3 of us doing some presentation. Katrina is on her way back to her office, so she may or may not make it. But definitely Kate's on the call, so she'll share some thoughts at the end. So we are Oregon Wellness Network, and we actually started a relatively short time ago. It was in January 2017, I think we first formed, and we actually had our first contract about November of that year and going into 2018. See here, is that moving? Oh, good, okay. So we're a division of Oregon Association of Area Agencies on Aging, n4a for short. And so the association is an association of all 16 AAAs that are in Oregon. And they created this division to see if there's some way we could sustain some of the health promotion programs that we've been doing for years, but which, funding is, always an issue. So the network hub, which is what Oregon Wellness Network is fashioned after the n4a concept of a network hub. So the hub contracts with payers, third-party administrators, vendors, et cetera, and then also contracts with its with the principal partners there's 16 AAAs, and that way the individual AAAs don't have to partner or don't have to contract, so everything is done through the hub. So our goal is to get to the centralized scheduling, recruiting, billing, contracting, and credentialing. Part of what we need is some sort of health information system that will help us with that. And that could also, besides help us collect information and present outcomes, that can also help us do our claims processing. So here's a diagram of what we look like. Okay. So the area agencies on aging may or may not actually do services directly themselves, but they certainly will subcontract with others. So that's that kind of mustard colored line on the bottom. But we do represent all 30 Oregon counties through our 16 AAAs. If anybody has any questions, they can ask. What you see here are some of the contracts that we currently have, and we are currently working on a number of other contracts. DBP, as you know, is now a covered benefit. Well, in Oregon, as of January, our Medicaid, or waivered Medicaid program is also paying for the diabetes prevention program. So we are in the process of trying to contract with all of those different CCOs. So in terms of our current data system, we have multiple systems depending on the program and service. A good example, again, is the diabetes prevention program. We have to enter the information on our Solaris system because they pay our claims, okay? We also have to enter the information on the Compass system, which it's a place where we can put in our schedules, and consumers can see that, and we can we also put in terms of after the fact, after the classes are done, and in terms of who attended, how many attended, and how many classes they attended, and so forth. But at this point, there's no link to claims or payments, so that's part of the issue. And then we also have to maintain our own Excel spreadsheet because neither of these systems have all of our cases on it, so that when we submit to the CDC, we have to have one that has all the information on it. So that means we have to maintain a separate one. We'll also have Oregon Access, which is where we track specific consumer information and their service use. And depending on the other contracts that we have, there may be more systems that we have to put the information on. So this is our biggest challenge, I think, is that multiple data entries, sometimes the same data, sometimes different data, but and just keeping it straight is a real challenge for us. And I'd love to hear if other folks are having some of those same issues. And then on top of that, we have to extract reports from these different databases, and some of them, they're not all the same. It's not like one report and you give it out to everybody. Everybody has different parameters, and so that makes it just challenging to keep track of. So this is about the Compass portal. I'm sure a lot of you are familiar with Compass. I know it's used by other states. And this is the one that Katrina was going to talk about because she's, Health Insight has taken over the management of this Compass portal, and she represents that organization. But right now we use it for scheduling classes. There is personnel management. You can put in who the leader is that is leading that. You can and then it requires 2 leaders, so you can put that information in there, and then you can track, who's taught a class. It also, the consumer can go in and look for a class and can also select that class, and the information does then go to whoever is operating that class to know that there's somebody that's interested in signing up for their class. It's really a data management system that was designed, or at least the one that we have, designed for our self-management and evidence-based classes. So example of things that go on to this one include the Stanford suite, or the SMRC suite of classes, like chronic disease self-management, chronic pain, and so forth. And also the diabetes prevention program. Okay. It has certain reporting functions, and the state, and Jennifer can speak to this, she does pull information off of this, so that off of this system, so that the organization doesn't necessarily have to send it to her. She can pull it off of this the system. So you have data at different levels, and this is probably where I'm not the best at this, but I could show you. And I don't know if Kate or Jennifer wants to step in. You can and address this, but this shows you the calendar where you enter your classes. Okay, and the way it is right now is that they allow 2 active users from each organization. So that can be a challenge if you're a large organization. But it has to do with the number of, you know, I guess, users that are in the contract. So you put your class in that calendar, and then you can select personnel to see the list of program coordinators and the workshop leader under the organization. It lets you put information about the group, and for example, the type of Compass user, whether or not it's program coordinator or the peer leader. It also allows you to put in the organization under which the workshop is being provided. Okay. And here's where you can actually add in your workshop information. I don't know if you can see that. And Solera is another system that we're entering our data on. And Health Insight and Solera, they're a national, Solera's a national DPP partner. In a sense, Oregon Wellness Network is part of their extensive provider network. So they are a little bit different than just a third-party administrator. They actually contract with different payers, Medicare Advantage companies, commercial payers, employer groups, and so forth. And because we're part of the network, then if there is a class that somebody wants to attend that we're offering in our area, then they would send that person to us via email, so we know they sign them up for our class, literally, and we get an email that shows that they are signed up for our class. So it's nice in that way. It's like a referral system. You do have to put in information, a lot of information, to get that person into the system, and that's what this is talking about. But they do some targeted enrollment campaigns, which is nice. For example, if we tell them we're going to be starting a series of classes in this county, then they and it times in with what they're planning in terms of an enrollment campaign, then it works out very nicely. you know, then all the stars align and we get referrals. That's the ideal. They also have online. Oregon Wellness Network doesn't do online, we just do in person, but they do have a network of online, digital and in person, it says here. So they do have a network of online as well. And ONS is a network member for Oregon. So we used to be at one time just their only network member, but since then they have had a number of other ones join. As I mentioned, they contract with payers and employers to cover the national DPP. And at this time, that's the only service that we are on their network for, is for NDPP, okay, and MDPP, okay. So they do bill Medicare Advantage. In terms of Medicare fee-for-service, they're still working on getting that capability, and we're hoping to see that soon. They do produce reports for us that are very useful. It tells us, gives us a snapshot of, you know, the data that we need to submit for DPRP in terms of whether or not we're meeting the percentage of classes that people need to attend, whether or not we're getting weights on everybody, and whether or not they're meeting the weight loss outcomes that are required. So that's nice to have, and they do prepare a DPRP reporting in the right format. The only issue for us is that they don't house all our data, and so we still have to depend on keeping a separate database so that we can make sure we don't miss anybody. They really only house the cases in which they have contracts and they pay for through their system. Here's the enrollment and payment process. Participants identified, screened, and enrolled in the workshop. Usually that's done either online or via a phone call, okay? And then once they're enrolled, then they determine if they have a payer that will cover them. So if yes, then they're signed up for a particular class, and the lifestyle coach gets an email that says, so-and-so signed up for your class, and you can click on that and it takes you to their profile, okay? The participant attends in person, hopefully, and then we enter the data back in, whether or not they come, so we use that to track their participation, okay? And once they reach certain reimbursement milestones, then a payment is generated from the Solaris system. And they also have incentives built into their system so that once you reach a certain milestone there too, then an email is generated to the participant to let them know, hurrah, you reached this this milestone, you know, and click here if you would like to, you know, get your incentive. So right now the incentives they use are Fitbits, which are really nice, and I'm not sure if I'm supposed to say that, but it is nice to have the Fitbits. So our search activities to date, everybody's so quiet. Is it because everybody's muted?
Yeah, they'll be asking questions at the end, Lavinia. You're doing good.
Okay. Am I doing all right?
Yes.
For time?
Yeah.
Okay. These are the systems that we've looked at, and there are probably some other ones that we did, but these are the ones that we actually had demos on. We started with Thrasis. We've seen at least 3 demos, and we actually got to the point of a redlining a contract. And we heard it was a great product based on feedback from other AAAs. Specifically, one that's on our team is Jessica Walker. I don't know if she's on the call from Texas, but anyway, so they were a beta testing site for Thrasis, and they really love it. But we're really having some issues with falling through on the contracts, and part of it is we're just tiny. You know, we're not a I think a big enough organization for them, but would really love to get their system if we could. The other one is the EHI, which is the one that Nikki was just talking about. We did see one demo. The demo we saw wasn't too impressive because it looked like a standard third-party administrator for, you know, office codes. So if I'm interested to hear from Nikki, just, you know, whether or not they can design it to work for us, that would be great. And then Athena, we saw one demo with that. Again, it was a real standard presentation. We shared with them what we were looking for, but and the person that actually demoed it, you know, really didn't hit on any of the things that we were looking for. So we know that they have, at least we've heard that they've developed a product specifically for DPP, but and I asked if they could demo that, but I haven't gotten any feedback on that one. And then the last one that we are interested in pursuing was the one that was presented last time, or at least mentioned last time, the care director. And love to hear more about that, and maybe get a contact outside of this, outside of the webinar to see if we can find out a little bit more about, you know, who to contact. I've sent them emails through their contact online, but haven't had a response yet. So still waiting for that. So I'm going to turn this over to Kate. She's going to do this part.
Yeah, hey, can everybody hear me okay?
Yes.
Oh, good. Yep. Yeah, hi. So I'm speaking more from the local area agency on aging perspective. Thinking about creating a billing system in a silo at the local area, it seemed completely daunting, if not impossible. So one thing I love about our Oregon Wellness Network is that it brings all the AAAs together to help develop systems and supports maximizing our strengths and areas of expertise. And that kind of leads to sharing and lightening of the workload. It also helps us create an economy of scale, which we've already seen help with applying for grants and contracts and vendor work. A great example is what Lavinia just presented on with Solera. Their AAAs getting payments for DPP work today that they would not otherwise have received thanks to Lavinia and the Oregon Wellness Network's work getting that Solera contract in place. So there's so many benefits for us all working together as a state that I'm just really thankful that we're moving along that path. We've definitely learned that we don't know what we don't know. So this learning collaborative has been really helpful, I think, for our entire team to hear from those that are maybe a little farther along or even at the same stage as us, those lessons learned, tips and tricks, pain points, just to kind of help hopefully our journey be a little less rocky than it would otherwise be. One thing that we've definitely, I think, learned is the need for project management and change management for all of this. There's so many of us. The AAAs in Oregon are very diverse, not just in our size, but the types of areas we cover and our programming. That kind of moving us all together really needs a coordinated approach and to help us develop an infrastructure that just won't work for us today, but will be nimble and flexible as we move towards the future. This is challenging, as you guys all know. Everything that everybody's been talking about through the collaborative is the technology needs to make this a reality. It's new for pretty much all of us here in Oregon, and it can be really hard to abandon our current state systems and practices because, again, we need to be building something that will work for us in the future. Another thing that we've learned, I think we've been talking about, especially after the last month's collaborative meeting, is the need to build out our business requirements before we really go into contracting for a platform. Don't put the cart before the horse, so to speak, and also sort of drawing a line with what's in scope and out of scope for that particular piece of our work. Sometimes it feels like it's 2 steps forwards, 1 step back, but we're definitely moving and making progress, learning those lessons really quickly and helping us get better as a network every day. That's what I've got. Jennifer, I don't know if you wanted to share anything, or I know Katrina just joined from our team as well, if there's any words that you'd like to share.
No, that was a great summary. I think, yeah, we're learning as we go, and this collaborative has been really helpful for helping to connect some of those dots.
Great. Well, thank you. So we're going to open it up now to see if anyone has questions for Lavinia, Kate, or Katrina. Okay, so we have a question from Nikki in Western New York. Do you plan to use both Compass and Solera, or do you have to use both of those systems for your DPP program?
That's a good question. We actually tried to have that conversation. We have an operations council, and we tried to have that conversation, but I think that's still part of the discussion. You know, I think everybody understands that this is a huge burden for any provider. It's just a matter of getting everybody onto the same page. There is obviously information that goes into Solera is necessary for billing, and it may not be the same information that necessarily has to go into Compass. So our ideal would be to have the information that is most comprehensive be the one that we enter it into, and then have the rest downloaded or something somehow transferred to the other system if that's what's needed. But I don't think we've gotten there yet. But very good question, Nikki. Thanks.
And Nikki, if you're in a place where you want to just, we can unmute you if you prefer to speak too.
Oh, that's okay. That basically answered that question. It does seem like a lot of these programs, when you have the billing, but you also have your project management part of it, or your coordination portal, that there's a lot of dual entry. So I was just curious with Solera if they're entering things twice, you know.
Mm-hmm.
And maybe Katrina, you could speak to this. I know that we've talked about some way of downloading the information to Compass that we put into Solera, so that we don't have to do that dual entry. I know that was discussion initially. I don't know if they're still talking about it.
Yes, we're trying to see what data we can. Health Insight is the license holder for Compass, and so one of the questions we'd looked at, as we also work with Solera under a CDC cooperative agreement, is what we could just directly download so that it was one centralized place, and then upload and have Solera do their screening for reimbursement from that point, or vice versa. We're still working through that. We just keep coming up against some different barriers to work through.
Gotcha. Thank you.
Great. And any other questions from the other teams? Okay. Great. Well, we can move on now to Lutheran Services of America. They're going to share an update from a consultation they received from Denise Chrysler, who's an attorney with the Network for Public Health Law. She covers the Midwest Great Lakes region. So we thought this would be helpful just to kind of get you guys thinking about opportunities where we can connect you to a subject matter expert for targeted consultation. And this one in particular was around navigating legal barriers, and particularly you may recall that Lutheran Services of America was very interested in consent and consent management. So that's what they'll be sharing with you today. So I believe Matthew is presenting for the team. Is that right?
I will be presenting the first few slides, and then the last two, I think if Nate on, Nate's going to cover the screenshot slide that shows a proposed approach to doing this electronically. I'll let you know when it's and Nate's slide, if that's okay.
Okay, perfect. Thanks.
Okay, so thank you, and thanks everybody for the time. Really want to just first level set in terms of what we're trying, what this consultation and what we were looking at from a legal perspective, the context that it has to our broader goal of implementing a person-centered care management approach, which increases access to care and sharing data across the provider community. And I know that, to some it may sound simple, but I think for most that are involved in this work, they know how challenging it could be, especially since work around data consolidation, data fragmentation, and consent management really isn't funded specifically, right? So it's, like what Lavinia spoke to, we're trying to avoid duplicate data entry, but share information with all relevant members of a person's care team and stakeholders. And in our case, in our model, that care team, oh, thanks for switching this. Did I switch that slide or no? I don't know if I guess I am in control of it. Thank you. In terms of implementing a model that shares information across a variety of providers, which are internal and external, there really are many challenges, right? And data, we use an EHR. We're also using Simply Connect as our care management tool to share data across the spectrum. But as folks talked about, there are spreadsheets and other portals, and all of that being one part of the challenge. Once you are able to consolidate all of that data, you really have a new challenge before you, which is, all right, I want to share information with an ecosystem of providers. How can I, from a compliance perspective, manage consent to ensure compliance and privacy, but without overburdening our clinical staff doing, consent management versus clinical work? So really sought out, and thanks to the, to getting us connected to those office hours, we're aware that there are people out there that are quite versed in the legal aspects of consent management. And we were lucky enough to learn some things during those office hours about best practices, such as multi-party consent. But we really were, humbly reminded that when you're sharing information in the health world realm, and for us, we're sharing information across health and medical, behavioral health, substance use, into social services, because we want to address social determinants. There really are best practices related to consent, which streamline some of the work. And although we can say, well, there are some tips and tricks, our analysis should always start with what information is being shared, with whom, and for what purpose. Because if you can't answer some of those questions, the compliance rules tend to fall apart. Minimum necessary is always a standard when you're sharing information with other providers. And most people say, well, isn't there a HIPAA exception to sharing information when I'm a treating provider? And the answer is yes. However, there are other laws which cover what information you can share and when, and HIPAA isn't your only consideration. Oops, sorry. Okay. So in other words, it's not one and done. It's not like you can do a comprehensive, multi-party release of information with providers that are internal and external to your organization and sleep well in terms of compliance and legal issues, because that would not cover you in terms of compliance with laws and rules that say, and rightfully so, before you can share my information about a Part 2 substance use service, or before you can share my HIV status, or before you can share my genetic condition with anybody, you have to ask me and tell me why. And those privacy rules are there for good reason. And the tension we're facing is, how can we as an organization, we're already, fighting challenges in terms of delivering value to payers. And I hate to throw this in, but we recently had a conversation with one of our payers about this project and our ability to share data and consolidate it. And they're thrilled and very excited about what we're doing. Clearly represents value to them for us to be able to do this, not only for the outcomes, but because then they have visibility to things that they didn't. The challenge is, well, why aren't we doing it today? Well, the cost of trying to do consent management on paper and managing those consents on paper, not only does it have flaws, but it doesn't facilitate that additional consent that's required when quote unquote extra sensitive information, such as that I mentioned about substance use or HIV, when that information is required, and I want to now say, oh, I want to share this with a provider because it's relevant, I need to contact that client and get a consent. Well, one, somebody has to remind me that consent is required. So really the challenge before us, and the office hours reminded us, this is a significant amount of work. You really need technology to help, or something, but technology is the answer we're seeking right now to help us achieve this massive responsibility. How do you know when you have to get an additional release of information? How do you know when your release of information is expired? Who's managing all of that? And even in many EHRs that will have a checkbox, did you get consent from the client? Yes or no? Although I call it like a kind of a feel-good button, because it's answering a really nebulous question. Yes, I got consent, for what purpose and to do what, and when does it need to be renewed, and when do I have to get additional consent? All of those questions kind of linger and would essentially fall on the back of the clinician or the program manager. So we took the lessons learned from a legal perspective, and we still, and we'll get this on the last slide, there's still more to learn. But how can technology help us achieve this responsibility for managing consents, informing the clients of their rights, recording those consents, and how can we do this where it's cost effective? Meaning, I'm going back to my, we have to keep our programs viable, which means we have to spend money that we're given on what's allocated for that money, and this is not one of those activities. So we have to keep this type of compliance management effort very lean, or it has the potential consequence of really draining a lot of resources. And we know with the margins we're all dealing with in this line of work, in the world of health and human services generally, or helping vulnerable populations, there isn't a margin for you to tap when you say, oh, I just want to spend a bunch of money on a system. So really looking to say, all right, what do we do next? Well, we're taking all these lessons learned from office hours and other materials that folks that are part of this collaborative sent us. So thank you for that. I think some of it was prior work of IPHI. We're now at the final stages of redrafting our release of information form, as well as our notice of privacy practices. Both of those documents have interplay. The notice of privacy practices has to be specific about certain things, and what the notice of privacy practices says will influence what a person is releasing when they sign a release of information form, as well as their rights related to that release of information form. So we're confident that we can get our ROI form, as well as the document that informs our clients about their rights, at a place where it's maximized in terms of its efficiency and in terms of its protection of us as an entity in terms of compliance from a legal perspective. One of the things we're considering is multi-party consents for some of our collaborating partners who are closer to us than other providers, meaning we've got MOUs or collaborative agreements with them, we've got projects going on with them, we work with them on a regular basis. Is there a better way for providers that you work with daily to capture and maintain consent compliance without having to do all this extra administrative work? And I believe there is an approach for there. We're also including in QSOA, Qualified Service Organizations, what QSO stands for, understanding that BAAs with QSO language or a standalone QSOA agreement will give you more compliance coverage when you're sharing information that's traditionally covered by 42 CFR. Now, does it work for all organizations? No, it doesn't. And between the time this deck was drafted and today, which like really wasn't much time, I've learned about 2 different types of agreements that other networks use to try to quote unquote streamline or find efficiencies in consent management. So in terms of our next steps, this is happening right now. We're gonna, we understand it'll never be perfect. We understand that our forms will evolve over time. We're gonna get them based on all the best practices we've learned to the best possible space, but not say it's done, because in a manageable way, these forms need to evolve with the lessons you learn over time. So in addition to that, and our great partners at Simply Connect, who in addition to our care management model, the technology we're using to share critical information with the care team, it's the care team inside and outside of LSSI. So it couldn't be a better fit when we're using technology to communicate clinical information with individuals that are inside of our organization or individuals that are outside of our organization. We need to manage the consent piece of that, and we look to our friends at Simply Connect to help, please. And Nate and team, to quick order, took what we were working on, and I think part of some of the things that they had in the hopper, so to speak, and I think have a viable approach. Of course, we're going to need a workaround for folks who technology, they have barriers to technology or otherwise, but we're hoping that those are the exception and not the rule, because of all the things I mentioned before about critical resources and being able to do this with an electronic platform. And I'm going to turn this over to Nate in a second, but I'm going to use real simple, non-technical language. I want to be reminded, if I'm a clinician, that I need a consent form. And if possible, I want that to be facilitated electronically. So we're not putting all of that administrative burden on somebody. We're not saying create another spreadsheet and start tracking this. We're saying, can technology remind me to get a form completed by the client, and can it capture that form for me if that's at all possible? And if we're able to accomplish this, what a huge, huge step forward this would be for us and for others similar to us in this space, because this is a significant challenge, and it's something we can't ignore. So how can we handle it in a cost-effective manner that really mitigates risk across the organization? So with that, if you could, Nate, if you want to talk about these screenshots. And
sure, absolutely. Can you guys hear me?
Yes.
Yep, we can hear you.
Perfect. So in talking to Matt and looking at this, so Simply Connect is completely integrated with their primary health record, their EHR. And so we have integrations that can help us manage that consent piece. But again, like Matt said, it was very, very simple, and it really didn't give the provider what they needed, and it really didn't give the patient what they needed. And really when we kind of took a step back and said, what are the big things that we're looking to solve, is really for the patient perspective, who has access to my data? Can they easily go in and see exactly which organizations are able to pull information down, and what information do they have access to? When I'm looking at this from the perspective of a community-based provider, being able to leverage those natural supports and some other social service type organizations that maybe don't have that standard health data engagement, how can I actually give them information that's meaningful to them so that they know, who's on my care team, who are the people that are responsible for different pieces of my life, who is my mental health provider, who am I going to for residential supports. If we're looking at, a shared care plan, to be able to share just those pieces out and really get out of the idea of we need to share everything with everybody, that if we only need to share certain things with family members or those social groups or other community-based organizations, that we should give the patient the ability to pull some of those things back, and for them to empower them to actually share data with others. If I have certain pieces of information like a med list, and let's say that I'm aging and I've got a younger daughter that's been helping me with managing my medications, making sure I'm going to doctor's appointments, I'd like them to be able to see what my med list is and when I should be taking those, but not necessarily everything else about my data. So looking at this from the perspective of how do we empower the clinicians to do what they need to do and have the information that they need, but then also making sure the patients can drive who can help them in the community and making sure they have access to that data. And so for the providers, the other thing that we've really done with this is really making sure that we've got an audit trail, that we've got proof that that they've been able to get the consent when they needed the consent. We can see exactly when those consents are going to expire, if they're going to expire, and really allowing them to get really granular and making sure that they are having the right conversations with their client base when they need to be having them. And not making this a guessing game, and really, again, kind of trying to lift that administrative burden so that it's just part of what they do, that it happens quickly, and they've got the tools they need to make it, happen. Anything else, Matt, that you'd like to add to that?
No, that summarizes well, but can you explain, because it took me a second to interpret, and I know I'm a little slow, but to interpret the 2 screenshots that you have, but can you talk about the mental health consent form screenshot and the access to my data screenshot quickly? Because I think that helps.
Absolutely.
Kind of just.
Yeah. So as Matt said, is that, essentially put this deck together last week. He's also heard of 2 new versions and 2 ways that he could update these consents. One of the things that we wanted to make sure that we had in here is that, we wanted to make sure that we can manage, general access to data, the mental health and substance abuse, and sensitive diagnoses. With those, we wanted to make sure we had version control, so that if there is an update or something that's been done, we know which version that people have consented to. And if there's has been a change, that again, we can use that as a prompt to say, hey, we need new consent, maybe before, as we're scheduling an appointment, or another way, so that when that patient or client is there, that we have, can give them a notification saying, hey, listen, we have a new version of the form, that it's easy for them to consume, and that they have the rights to give consent and they know what they're consenting to. So that's kind of that blank consent form, is the fact that we can take that information and make sure that we can tailor it and display it. It isn't something that needs to go back to coding to do. If we have a change that needs to be made, we can make those changes and make sure that those are easily communicated out. So if you look at the image on the right, the access to my data really is about getting to that granular piece of information. So if you are a provider of services, I think Matt started out the conversation with saying, you have access to certain things. But maybe there's some things you don't need, and being able to communicate out saying, hey, here is the information that I know that I need, but maybe I don't need these other pieces of information, and being able to communicate that out, let them know that, hey, this is what we need and what we're going to be asking for when we ask for consent. But then also giving them the ability to, if they want to give access to their data to somebody else, or if there's been a referral and they're saying, hey, I want to be able to get a second opinion, or whatever those things are, that again, they're able to do that in a way where we do empower that patient or that client to have some say in what's going on. Again, if you need access to everything, they can't say, well, you can't have access to this and receive the services, but to give them some control where there's opportunities to that. And if it's not a control piece, at least it's a really easy conceptual visual way to say, here's what I'm sharing with this individual and here's what they have access to.
Great, thanks, Nate. So let me go to the next slide. So one of the questions we wanted to throw out, and it is one that I continue to socialize to all of our collaborating partners and the networks that we're part of. There are folks that are doing this in a way that's more efficient or novel than others, and we've learned that through some of the office hours. We've learned that with some of our internal discussions. But if anyone has other examples or document examples of collaborative agreements or multi-party consents that have a unique approach to consent management across a number of providers that may or may not be related from a financial or a business perspective, but are working together to integrate the care for somebody in the community. If anyone has any of those, that's our open question, because we're still thirsty for knowledge in terms of, who's doing this, what's the best practice as it relates to multi-party consents and collaborative agreements from a consent perspective. And we think we're getting close, but we're convinced that there must be more out there. So if anyone gets or hears of anything, please send it our way, or to the folks on this call, because really looking to make our approach as strong as possible.
Thanks. And if anyone has an answer or can point to more multi-party consents, feel free to jump in here. In the meantime, we have a few questions for you, Nate and Matt. So I think because Nikki and Lavinia both asked a few questions, so I'm just going to ask them to jump on the line. Lavinia, why don't you go first, because you have a few questions.
Yes, okay, thank you. Just to, we are looking at our consent form right now too, primarily because we use the state, the DHS forms, release of information, and they've just come up with a new form that used to allow multiple parties and now only allows a single party, so 1-to-1. So I wondered whether or not you've noticed a movement away from multiple parties. That was my question.
So there is a body of law out there that says, when you're truly giving informed consent, that's what are you sharing with whom and for what purpose? And sometimes that multi-party consent, when they're too nebulous and there isn't a regular connection or relationship between the providers in the network, I'm not going to say there's a movement against them, but I think that the privacy advocates really want informed consent to be simple and clear, and not have 12 different places this information can go, if it's at all possible, because then they say you're moving away from really explaining to somebody what can happen with their data. That being said, I think that just recently, I've heard of a couple different approaches to multi-party consents. Some deal with providers that are, like I said, tied or vested financially and otherwise under an umbrella organization. Others who are just collaborating providers in an ecosystem. And I think that we're tending to be more conservative on the private side. We're not going to do anything that even falls in the fuzzy land of are we in compliance or not with the law. We're going to go that extra step. So we haven't made the full decision to use multi-party consents. We have a couple different tools that we're using with some of the networks we participate in. But if I find anything else that weakens multi-party consents or their efficacy, Lavinia, I will let you know.
And that was one of my questions. If you would share any final products that you come up with, we'd love to see them.
Sure.
Yeah.
And your question about verbal consent, I don't know if I understood that, Lavinia.
Oh, that's when you record them.
Oh, Nate can talk to that. I don't think they're recorded verbally. Nate used multi-factor authentication to get consent IDs on the people that are consenting, but I can ask Nate to answer that question.
Yeah, so we're not currently getting verbal consents or recording verbal consents, but it is about making sure that we validate who that person is and then give them the electronic way to accept the consent.
Oh, okay. I misunderstood that. Thank you.
And then Nikki, you have a question?
Yeah, I have a couple follow-up questions from that last conversation, but my first question was, if we're linked in with our local RIO, and one of the things our local RIO does is obtain consent from any person that has their information shared through their system. So if we become a member of the RIO, then are we covered under that? I mean, I'm meeting with them next week anyway, so they'll probably be able to tell me, but have you guys talked to your RIO about that?
So I think,
yeah, go ahead, Nate.
No, go ahead, Matt.
I was going to ask, I'm not familiar with RIO, I'm embarrassed to ask, but when you say RIO, what does RIO stand for?
Oh, your Regional Health Information Organization, basically.
Yeah, we don't have one of those. But I can tell you this, just generally. So whatever entity, umbrella entity you're working under, RIO is the entity, and they have a consent form that the client signs before they send or share information back for it. Generally, those consents do apply. However, what I would ask your RIO is, what about consents that fall outside of HIPAA, such as 42 CFR? And they may say, yeah, we're covered because, and then or it may not be relevant because we have language in the consent that falls under we're a qualified service organization, and then there's a BAA in place. We have documents in place to cover you. But I think that's a good question for you to ask them, because it's more than HIPAA. It's those other more strict laws. And like I indicated, you can sign a business associate agreement. Like if you're a business associate to your RIO and they're the covered entity, so to speak, and they have the right language in their BAA, yeah, you may very well be covered.
Okay. It just sounds like I got to find more information, which makes sense.
Yeah, and it really does depend state to state.
Yes.
Every state's going to have different rules, especially around the substance abuse and mental health. But as Simply Connect has a backend that is a health information exchange, and so it does. I think that it's kind of twofold. So there's making sure that you're covered, but then also making sure that the people that you're supporting really have visibility to what's going on. And so I think that there's two different pieces there. There is kind of those blankets that give you covered by a legal standpoint, but it really isn't informed consent and a lot of standards for that client.
Do you guys find in your population of people you're serving that there's a segment that doesn't have access to technology? Do you have a plan for their consent?
Yeah, those are the workarounds of that. Yeah, go ahead, Nate.
Yeah.
Yeah. So we have a client version of our application and portal, and we've also got a provider application for mobile application and portal, and we'll support if that client does not have the technology, that we'd be able to allow some of that verification of who that person is, and to have that provider actually sign within their app or use their application to have that person give consent through their login. So we'd lean on the provider then to get consent from that person.
So is that when that person comes in to see their provider?
Correct. Or meets them in the community, however that looks.
Well, I think we have a large population too that is somewhat fearful of technology, and even phoning. They would rather do something on paper, in person, with somebody explaining it to them. We've run into that a little bit with just our billing system. Them getting consent from people, and the people don't want to, or they don't follow through, and so forth. So, it would be interesting to see how you address that challenge. One of the
and a conversation needs to happen for sure. And I'm sorry, I think a conversation needs to happen for sure, and educational materials are a part of it, so that they do have something they can take away, whether they have the technology or not, to have it in their hands. But right now we're running at just under 99% of people that are opting to share their data. So we're doing really well. We're working with our clients to make sure that they.
Wow.
Yeah, just under 99%. Yeah.
Is there anything that does 99%? That's great. So it does raise an issue. Of course, all this discussion raises my awareness about other things that are happening in our state. We have, and other folks in my state can jump in, but we have the EDI system. Are you familiar with that?
Yes.
No.
The EDI notification.
Yes. Yeah. So we have different agencies have access to that, and we can look up our clients' information. And the issue about CFR 42, but also just about the whole. There's information in there about mental health and substance abuse treatment and so forth. And I mean, how do we? I'm not sure that anybody's really talking about it. Maybe they are, but it seems like that information gets shared relatively freely.
No, you're right. No, you're absolutely. I'm sorry to laugh, but we've been surprised at how freely information is shared. But it's clear. I mean, some information can be clearly shared based on what you're doing. You're a treating provider. HIPAA will let you do it. However, some information falls in the separate bucket of it's more sensitive than traditional healthcare information. And those two examples that you gave, I mean, any certain substance use treatment, HIV status. Those are things that require an additional consent, another layer of consent. So somebody has to ask the client, do you agree to allow me to share this information for this purpose? And every time that type of information is shared, an additional consent is required. Now, but you're absolutely right. It's really lax out in the field, but that is going to change over the next few years. It's just going to tighten up because these types of things tend to regulate themselves via lawsuits, and no one wants any of those.
Yeah, so it seems to me, because when I worked public health, I was told that I had to, if a judge asked me to share information about one of our clients who was under drug treatment or whatever, that I had to refuse unless they got, a signed consent, and to the point of being in contempt, and I had to be prepared to go to jail. So it seems like we've gone the other way in that maybe now the pendulum swung quite. I mean, I think it's good to have, to be able to share information, but I think there's sometimes where there's information shared that I don't think we all needed to know.
Great. Well, I just want to say thanks to Lutheran Services and Simply Connect for sharing with us. This was really a useful discussion, and for others for chiming in here. We wanted to move on to the work plan updates. So I know we've heard from Lutheran today already in Oregon as well. So we were just going to have the other teams that haven't had as much of a chance to speak yet to give some work plan updates. And I'm going to pass that to Lori.
Great. Well, this has been really interesting discussion, so thank you, everybody, for sharing. So we'd like to see if Maryland, Western New York, and Age Options have anything that they'd like to share in terms of an update. So any activities that you have completed in the last 1 to 3 months that you haven't shared on a webinar yet, or a hurdle that you need to overcome in the coming 1 to 3 months, or a question or a challenge that you want to pose to the group. So I know that we sort of teed you up with that prep before this webinar. So Marilyn, if you have anything you wanted to share.
Sure. I think what we have been working on with Tim McNeil is we actually are in the process of negotiating 2 different contracts with these physician practices, because of course we know that Maryland's on the new Maryland primary care model. So we actually have the contract written where we're going to deliver pearls and enhanced wellness and collect 20% of what they bill. So we have the contracts are almost finished. So we've trained over, I guess, in the last 6 months, my 40 people into pearls. We've also trained them into enhanced wellness to be able to get to this billing point. We have also just hired an ANP, a nurse practitioner, so we can start to bill in this chronic care management. So I think for the first time, we feel like we're getting somewhere.
Great, thank you. How about Western New York?
Hi, this is Nikki from Western New York Integrated Care Collaborative. We are also working with Tim McNeil.
He's a busy guy.
We were originally really vetting Thrasis for our IT portal. And as Lavinia shared, we're just too small for them. And, they even came out and just said, we've got other big projects. We'll put you on our list down the road. But we decided, our board decided we don't want to wait for them. So we went back to EHI that I mentioned earlier and got 2 more demos from them. And really, through this learning collaborative, you guys have helped me really figure out what questions to ask and make the demos. So I sent them questions ahead of time so that when the demos came through, they were more around what we needed as opposed to just a general marketing demo that kind of didn't really answer our questions that we had in the past. So that was helpful. But they still are costly if we just contract directly with them, and we haven't officially billed yet. We are almost contracting with 3 different health plans. We've been in negotiations, one to do chronic care management, one to do Healthy Ideas depression management, and that's actually for 2 of them. And so we need to have this portal in place. We can document, and we have 6 or 7 different network partners that we're also a hub similar to Oregon Health Network, where my organization's the hub that contracts with the health plan, and I have to have separate contracts with all the network partners that are going to actually provide the services. So I've been working on getting all those contracts in place and getting the contract with the health plans. And so with the health portal, Tim found us a physician practice that uses the EHI that sounds like they are willing to let us work under them and then have access to EHI through them. And then as our CCM model grows and we need clinical oversight, they would provide that. They have a license in New York State. So so it's sounding like it's coming together. More to come. Yeah, more to come on. Once I get things signed, I'll be really excited. Everything's coming.
That's great. That's great. All right, so how about age options?
Well, this is Joan from Age Options. I did report a little earlier, but we are working with Harry, who is the owner of Workshop Wizard. He's the creator. And we're working to update our data management system so it allows us to create more related reports. One of our hurdles, of course, is in order to update systems even further, we really have to look at our funding and our, what our budget allows us to do. That's where we are right now.
Right. Anna has a question for you.
Yeah, I had one question to circle back to Nikki real quick. The physician practice that may be close to giving you access to their system, how did you connect with them and kind of what's in it for them, or what, do you have a sense of what the scope of the contract will be? I'm just thinking if others want to happen to land on a similar pathway, how you got there.
Yeah. Or, Well, Tim McNeil brought them to us, but so the initial pilot we're doing with the health plan for the CCM, we don't need clinical oversight because we're doing it on a small scale and the health plan's going to take care of that. So initially, the physician practice will receive a percentage of our billing as basically administrative fee for allowing us to use the portal. And then as we go forward and go beyond the pilot, the health plan wants us to go from servicing somewhere in the 400 range of members to thousands. And at that point, we'll probably need our own clinical oversight, which this physician practice is willing to provide for us. And they actually talked today about opening an office right in Buffalo. So, so it's kind of exciting. We're bringing them new business, but at the same time, they're allowing us to get this portal going so we can move forward on all these different projects that in our state too. We have our MLTC plans, the managed long-term care plans, which deal with Medicaid, have to contract with a tier one community-based organization that's a nonprofit, and they have deadlines. And so we are set up, we are a nonprofit, and so we qualify under all those contracts. So I'm getting calls all the time now for MLTC plans and providers that are required to set up these contracts. And so we have to be ready to be able to not turn business away and have this portal in place. But yeah, that's how we're setting it up with the physician practice. But we don't have a contract yet. So
that's wonderful. Will it be a % of revenue? Is that what you said?
Yeah.
Yeah. Best way to go.
Yeah.
Yeah.
Thank you so much, Nikki. And Joan, I'm sorry I didn't properly close you out before we posed that question to Nikki, but thank you, Joan, for sharing the update from Age Options as well.
Oh, you're welcome.
All right. We just have a couple minutes left, so we're going to abbreviate the final things that we wanted to cover and move through those fairly quickly so we can end by 2:30.
Great. So just a few updates here. You may recall from the application for the Learning Collaborative that we are planning to arrange some technical assistance opportunities with subject matter experts. So I think the presentation today from Lutheran Services of America was one example of how we can match you with a subject matter expert. So that was with the Network for Public Health Law. And we know that there was some specific interest in connecting with Sharon Fusco, who presented on the last full cohort webinar. So what we plan to do is we have a TA request form that's a Google form that we'll be emailing you to capture these requests. And then what we'll do is match you to the appropriate subject matter expert based on the topic that you select. And then from there, we're kind of going to step back and have you work directly with them to schedule time that's convenient for your team and the subject matter expert. We will try to be on those calls if we can be, but really we ask that you just, we'll have some minimal guidelines around just documenting what was discussed or what was shared and what the key next steps or takeaways are. And just like we had the Lutheran team to present today, well, we might ask you to circle back to either the work group or the full cohort and share what you learned from that conversation so that everyone in the Learning Collaborative can benefit from that. So this is coming very soon. We're just working on finalizing the agreement with the subject matter experts. And if you have particular individuals that that you would really like to consult with, let us know because we can reach out to them. We have a few people in mind, like I mentioned, but we are open to other ideas. So Antonia has spent a lot of time going through the data that we've collected from conversations with each of the teams across the 2 work groups, from webinars, the office hours, the initial call. And these are the buckets that we've identified for this TA arrangements with SMEs. So the legal questions around legal issues, data integration with healthcare, that could be with HIEs or RIOs or with health plans, specific questions about vendors or software products, data analytics, screening and outcome measures, and then specific attributes of systems like billing or receiving payment from Medicare or supporting the hub models that we've talked a lot about today. There are certainly other topics that have come up, such as business acumen or making the values proposition, change management, understanding social determinants of health data. Those are topics that we feel like we can cover through the Learning Collaborative. So if you don't see something that you've shared with us reflected here on this list, we do have that documented and teed up for future content through the Learning Collaborative. So are there any quick questions about that? Okay, so guidance will be forthcoming soon via email. Just stay tuned for that. We have our next full cohort webinar on May 1st, and you may be familiar with N4a facilitates a similar learning collaborative called the Trailblazers Group. They've actually already been meeting for over a year, and their focus is more on the contracting side. And they're really interested in connecting with our learning collaborative around the data system piece. So we'll be doing a joint effort for the next full cohort meeting, so stay tuned for that. And I just want to kind of walk through quickly. I know we did this on the last call, but we've added a few assignments here. So I think the conversation today really illuminated, you guys are continuing to have conversations with vendors and progressing in either coming to a standstill and realizing you're not going to sign a contract with a particular vendor, or you've had some more conversations with other products. So are we going to pull it up, or we don't have to? We've gone through your the profiles that you've completed, so we've gleaned as much information as we can about the systems that are currently in use. And Lavinia, I know that was really helpful what you shared today about Compass and Solera. So we've put the names of the teams that have mentioned certain products or tools that you're exploring, and we've highlighted it here. So we ask that as you have a conversation with a vendor or learn a bit more about a product, that you continue to go into this spreadsheet and update the information here. And then we're also going to be looking to some suggestions from you about the attributes or the definitions for some of these key features. And we have some material that we can share and post on the online community as well that might help us pull from other publications that have already been released. So are there any questions here? So if you see your organization highlighted by the next full cohort meeting, if you can go in and update the information or scratch it off if you have no information about that product, because you're actually not going to be talking to them. Okay. Then the other piece we have is the key takeaways document from the conversation we had with Trinity Health System and the WellCare MCO. And I think particularly this does, so it doesn't have to be from that conversation, but as all of you have continued to have conversations with other organizations, and then you get referred to another entity, please, please, please go into here and just, put some high level takeaways, the main learnings, and put your agency or your name next to it. We, as a part of this learning collaborative, will be producing, some products at the end, and this will be one of them. So we might circle back to you to help flesh out the information a little bit more. And I think the learnings around consent management that were shared today will be a nice, standalone takeaway as an example. So let's see. I think the only other thing from us here is just to let us know, and we put this in the evaluation at the end, but if there are tools, or if you or someone who wanted to learn what you've been learning as a part of this learning collaborative, think about the products or deliverables that we should be producing, and give us suggestions around. It would be really nice to have a two-pager on the following, or I really wish there was a toolkit for this. That will help us kind of finalize what that short list of deliverables will be. And as always, check out the online community in the All-In platform. There is an upcoming webinar that is hosted by Siren, which is a funded by RWJF out of University of San Francisco, and they had some funding to examine care coordination and closed-loop referral platforms. So they'll be unveiling their learnings from that research and a webinar in a couple weeks, and then they'll also be releasing a report. So that might be of interest to some of you. And then the TA request form will be coming out soon. And I think that's it from us. We ask that you just take a couple minutes at the end here to complete the evaluation, and we hope all of you have a great rest of your afternoon. Thanks again for presenting and contributing to the discussion today.
Thank you.
Thank you. Thank you.
Thank you.
Bye, everyone.
Thanks.